Hi guys, I'm Saad Abbas, I'm your clinical tutor, and I try to bring these subjects for you in a very condensed but comprehensive form. I have chosen today an important topic that we see very often, and I expect junior doctors and medical students to be aware of the state of this problem and how we manage it, and that's management of a pancreatic mass. Now, how does that come to our attention? Is depends on the patient's symptoms. Usually, the patient's symptoms, if it is relevant to the pancreas, it's going to be alarming. And these are in the form of ongoing epigastric pain for weeks or months, or they develop obstructive jaundice, or they lose weight, or their appetite is gone, then that's already flagged for pancreatic cancer. So it is a serious diagnosis to have. And it's very important that when you talk to the patient, you be really careful how you inform the patient about the problem that we have, because it's likely that in the first instance we have a mass discovered on CT scan, either as an incidental finding or as a result of investigation because of symptoms related to the gastrointestinal tract, and we find the mass in the pancreas. It's not always doom and gloom. It's not always bad. You should always provide hope to the patients and make sure they see there is something that can be done about what the problem is, and they need to know that we need to work carefully through it to find the exact diagnosis. The other thing that you need to keep in mind is consider always the differential diagnosis. Think about what could this mass be. A thorough history and clinical examination is very important. If you find the patient has lost weight and are emaciated, or they have got enlarged liver because of metastases, or they have another stigma of disease related to the cancer, or they have any abdominal mass in relationship to that, which is quite unusual. The only time you could feel a mass is when you have extensive liver metastases, but unfortunately, in these patients, the deterioration tends to be rapid. And then we need to go through doing the basic things, which is the basic bloods on the pancreatic protocol. CT scan is the minimal that we need for investigation of the mass. Now, what could the mass be? I think I have mentioned that in the past, and I'll repeat it again. Whenever there is a mass in the head of pancreas, the top differential diagnosis is that adenocarcinoma of the pancreas. Pancreatic neuroendocrine tumor, they are not common tumor, but in my line of job, they get referred to me as a hepatobiliary and pancreatic surgeon. So I see quite a lot of them, and they tend to vary in their extent and their behavior, their biologic behavior. And we cover the management of neuroendocrine tumor in a previous video. Every now and then we face a problem, which can be quite a dilemma that we face when we get an inflammatory mass in patients with acute, particularly acute or chronic pancreatitis, and that can be quite hard to discriminate between cancer and inflammatory mass in the pancreas. So we need to see if the patient has history of chronic pancreatitis or any attack of pancreatitis in the past. Sorry. Lymphomas, every now and then we get a patient with mass in the pancreas, and when we investigate them further, we will find that it is a lymphoma. The area is rich with lymph nodes, and the primary site of the lymphoma could be the pancreas itself, usually in the head of the pancreas, but there are cases of cancer on the tail of the pancreas, either the lymph nodes, the peripancreatic lymph nodes, and then that grows into a pancreatic mass, or right from the pancreatic parenchyma is unknown. I think it all developed from the local regional lymph nodes, but it's hard to discriminate on imaging between a mass in the pancreas or a mass arising from the lymph nodes in the vicinity. We should also consider the possibility of metastases. So patient history is going to be very important. And the cancers that metastasize to the pancreas that I have dealt with in the past is renal cell carcinoma, breast cancer, melanoma, Merkel cell tumor. And this Merkel cell tumor is a cancer of the skin, which is highly aggressive and can metastasize to different visceral organs, and including the pancreas, and also the possibility of lung cancer metastasizing to the pancreas. Other than these tumors, it's pretty rare for other cancers to metastasize to the pancreas. So now we know our differential diagnosis, we know what could the problem be, and this knowledge plus the fact that we have a CT scan with a pancreatic protocol should guide our investigations. The important things about the routine bloods, you're not only looking at whether they have got renal failure, it's UNEs here, meant to be, I'm in a hurry. So the routine bloods will not only show you the hemoglobin that will be of relevance or renal function, or whether they are developing obstructive jaundice or not. The other factors which are very important, particularly if they have pancreatic cancer, I look at their lymphocyte count, because lymphocyte count will tell you something about the patient's immunity, also about their nutrition. And very often patients with cancer and chronic illnesses, they have low lymphocyte count, which by itself is a bad prognostic criteria. Platelets count. A lot of cancers incite a powerful systemic inflammatory response, where you could see their platelets and CRP are elevated. And if these are elevated in patients with pancreatic mass, it doesn't actually mean pancreatitis. It might, despite the fact that the patient might have presented with a mild attack of pancreatitis, but this could be just the inflammatory reaction from the tumor. And pancreatic cancer can relatively commonly cause this problem of systemic inflammatory response with raised platelet, CRP, and fever. Also, the albumin informs you about not only the liver function, but also the nutritional status of the patients. Tumor markers, and I routinely request CA19-9, CA, and chromogram for any pancreatic mass. You don't need to do other markers. Now, the most important marker, as you know, in ductal adenocarcinoma CA19-9, it's not diagnostic, but it's very useful as a prognostic tool. But with the test, when we do it, it has a low sensitivity and specificity in the about 87 to 89, which make the accuracy of the test in detecting cancer not that great, but they are very useful in the follow-up to see if the patient develop recurrence of their tumors. Same thing will apply for chromogram A for neuroendocrine tumors. And now hopefully we have got the CT pancreatic protocol ordered, because usually the mass has been discovered on just a portal phase, the venous phase CT scan of the abdomen. So we need a specific pancreatic protocol that you request from the radiologist, and it's all about timing of the imaging. The pancreas enhances maximally in about 60 to 70 seconds after injecting the contrast, and that can make the mass, usually if it is adenocarcinoma, it's of low attenuation, and it will look darker than the rest of the parenchyma of the pancreas, less enhancing. While if it is a neuroendocrine tumor, it will be more enhancing than the rest of the pancreatic parenchyma, and that can give you a good idea about the nature of the tumor. The CT scan, as we mentioned in pancreatic cancer, there are several things that we need to look at in a CT scan, not only the mass itself and its size, but also its relationship to the surrounding vascular structures, and these are the superior mesenteric artery, superior mesenteric vein, portal vein, and the common hepatic artery and the splenic vessels in case of the tumor of the body and tail of the pancreas. It will also show us if there are metastases in the liver. We do chest, abdomen, and pelvis to ensure there is no fluid in the abdomen, and also no metastases to the lungs. We use PET scan, and the purpose of the PET scan, as we do in other cancers, it will look at the primary tumor and it will give us an idea whether it's enhancing or PET or not. And the PET, when I say a PET scan here, I mean it's the FDG scan, and that usually is useful in duct adenocarcinoma, while in neuroendocrine tumor, they tend to enhance very slightly on the ordinary FDG PET scan. PET is also useful every now and then. It detects a metastases in an unexpected place like bones or spinal column or the chest. And also every now and then we find that that single mass that we see on the CT scan of the abdomen is not on its own, and there are large lymph nodes elsewhere, particularly in the mediastinum, in the neck, and in the axillary regions, and these will be amenable for percutaneous biopsies. So the PET scan will be quite useful as a diagnostic and staging tool for lymphomas. If we think the mass is actually a neuroendocrine tumor, we do the dotatate scan. And the dotatate scan is a gallium PET. It's another form of PET, a molecular imaging that detect neuroendocrine tumors. Historically, in the past, we use what we call octreotide scan, which is the somatostatin analog. And now this is kind of being more taken over by the dotatate scan of the gallium PET. People ask about the role of the MRI and MRCP. We will do an MRCP if we think there's any biliary pathology, particularly if there's dilated bile duct and there is no mass in the head of the pancreas. Also, MRI of the pancreas could detect more masses in the pancreas than the CT scan. So it's a little bit more sensitive than the CT scan in detecting masses in patients who have obstructive jaundice and no obvious mass on the CT scan that was taken earlier. Now, the last thing that I wanted to mention to you is the role of endoscopic ultrasounds. Now, endoscopic ultrasound has actually revolutionized the management of pancreatic lesions in general. And today, we're only talking about solid masses in the pancreas. So it's an ultrasound probe mounted on an endoscope that looks like a gastroscope, where the experienced endoscopist will go in there and they can have a closer look at the pancreas to describe the mass, the features of the mass, its size, its relationship to the surrounding structures, particularly the vessels. If there is vascular invasion, it's very sensitive and give you an accurate picture about the mass, and that could be applicable to masses anywhere in the pancreas, whether to the right or to the left of the superior mesenteric vein. The other advantage of the endoscopic ultrasound is the fact that we could do FNA and biopsies, and also assessment of the loco-regional disease, which is basically looking at the lymphatic basin that drain the pancreas and see if there are any large suspicious lymph nodes. The procedure is very safe, and the complication rate is very small, and rarely the patient can have minor bleed when they do FNA and biopsy, or they could have mild attack of pancreatitis. And it's essential tool these days for management of masses in the pancreas in general and pancreatic cancer in particular. Thanks for staying with me for the length of the video, and I hope I will see you in future lessons.